Hello, you've tuned to this week's episode of Next Steps Forward, and I'm your host, Chris Meek. As always, it's an honor to have you with us. Next Steps Forward is committing to helping others achieve more than ever while experiencing greater personal empowerment and well-being. Over 4 decades, the opioid epidemic has devastated families, overwhelmed communities, strained healthcare systems, and claimed hundreds of thousands of American lives. My special guest today is Richard Baum. Richard has served at the White House Office of National Drug Control Policy for 28 years in a variety of positions through 6 presidential administrations, including 11 months as the office's acting director. He has also served as executive director of the President's Commission on Combating Drug Addiction and the Opioid Crisis. And he's the author of the book, Hard Lessons from Inside the War on Drugs, which was released earlier in 2026. Richard Baum, welcome to Next Steps Forward.
It's an honor to be here. I look forward to the conversation.
Likewise, I appreciate your time. A very, very important topic for us today. So, Richard, I've read that there were 3 waves to the opioid crisis in America. The first was the prescription opioid wave from the late 1990s to early 2010s. The second was the heroin wave that began around 2010. And the third was a synthetic opioid and fentanyl wave that began around 2013. First is an accurate description, and then what accounted for each of those waves in terms of supply and demand?
That is right about the first 3 waves of the opioid crisis. Around 2013 is when we first started seeing these fentanyl overdoses. In the decade or so since then, the drug use patterns have gotten more complex and now involve co-use with stimulants and sedatives. So a lot of us consider that the fourth wave, polydrug use, still involving opioids, but now involving other very addictive and sometimes complicated and dangerous substances.
What are the most important statistics that people should know about opioid addiction and overdose deaths?
Yeah, it's a really good question. Uh, you know, um, uh, Fatal overdose, annual fatal overdoses were about 70,000 in the last 12 months that CDC has available data for. That is down from the peak of about 109,000 in 2022. But so we're glad to see it moving in the right direction, no question. I mean, that's progress. But also historically, it's still an extremely high number. And I would just say that before Purdue Pharma launched the opioid epidemic with their release of OxyContin, and we can talk more about all that. But overdoses were 5,000 a year, and we were worried about that. And so it's for someone who's been in this field and drug policy for a lot of years. It's still shocking to me that we're losing a football stadium full of Americans every year, and clearly that is not a satisfactory outcome. We have a lot more work to do.
I'm glad you named Purdue Pharma. We are going to get to that, and I want to call them out and name them, and anybody else you think should have, a red mark on them. How does the loss of life from opioids and fentanyl stack up compared to other major public health crises in American history?
Yeah, it is a huge and really dramatic overwhelming cause of accidental injury, death by accidental injury. And I did just look it up. There are about 43,000 car accident fatalities a year. If you combine all gun violence, homicides, suicides, accidental gun deaths, that's 45,000 a year. From the flu season. Last one was a big one. About 45,000 also died, 24 to 25. I did look up COVID-19 deaths, which, and I do worry that it's a little bit numbed us from some of these numbers because those numbers were so high. But COVID-19 deaths were 50,000 in 24. They peaked at 462,021, and so they've come down a lot. But they had this huge, peak at the worst of the epidemic, which was a nightmare for the country. So, in summary, it's a hugely consequential cause of death in the United States, and worthy of attention.
As evidenced by 6 presidential administrations, putting some eyes on this, and we're digging into that as well. How did opioid use and abuse become so widespread in America in the first place? Were that many people in real need of pain control? Was there much of the crisis, just people looking for cheap fix?
Yeah, those are really good questions. So on the one hand, uh, the country has had opioid epidemics in the past. In fact, the original epidemic was really morphine back 100 plus years ago. And then we've had waves of heroin misuse, including in the 60s and 70s, and then in the 90s as well. So, on the one hand, opioid misuse is not a new thing. But what was new was this bulge of prescription opioid painkillers that were released on the country from Purdue Pharma. And I think it's important to say Purdue Pharma, through their marketing, lobbying, and legal and PR and advertising marketing strategies, they uh, they launched this the prescription drug epidemic, and they deserve that blame. However, they are not the only ones. Other pharmaceutical companies, Janssen Pharmaceutical from Johnson and Johnson, and others jumped into it. And I guess the reason why I feel like it's really appropriate to zero in on them is they worked very hard to persuade doctors and medical professionals, health professionals, that hey, our pills are different. There's a coating on it. People won't misuse it. People won't get dependent, and it's safe outside the hospital setting. And Chris, I'm really confident I don't have to tell you as a doctor, but it's not a new idea in the medical profession that opioids are risky to use outside the hospital setting. And that's why for years, doctors kept a pretty close hold on it. Well, Purdue Pharma knew to make a billion from their product is they had to loosen up those constraints, and they had a very misleading campaign to say their substance can't be misused and it's not a problem. So, yeah, it's a man-made disaster. And just to go further, once you had about 10 million Americans misusing opioids in the country, this giant bulge of addiction. Normally in substance misuse, it's alcohol and marijuana. Those are the big ones. And then the harder drugs, cocaine, methamphetamine, heroin, they're relatively smaller. But what Purdue Pharma did is took this relatively small concentrated problem of heroin or opioid misuse and turned it into a mass problem. 10 million people misusing opioids a year, many developing a substance use disorder, and that created a huge bulge. And so that is why we became so vulnerable to this transition to heroin and to fentanyl and the problem we're still on today. And that's why I believe it's a strong case to be made. They're very responsible for the opioid crisis, even though it's almost 30 years since OxyContin was released, because they normalized opioid misuse. They addicted 10 million people, and there's that bulge that we're still dealing with. It's not the only route, right, to opioid dependence, but it's the primary one.
So maybe a couple follow-up questions there. You talked about the marketing campaign and the persuasiveness with some doctors. Did the doctors just underestimate the addictive nature of this, or were they looking the other way because they're being seduced by, conferences and retreats and things like that? Or I mean, they're
Yeah,
doctors.
I think there's a continuum about doctors. I do think that some were, well, I understand, doctors are busy. They've got a lot of patients they've got to see. They have a lot of patients complaining about and concerned with pain. And the pharmaceutical reps presented a good case. And if those who haven't read the book Dope Sick or seen the miniseries on Hulu, where Michael Keaton plays the doctor, I really recommend it because it shows how a well-intended doctor can kind of get drawn in to using these medications, just testing them and see how it goes, and get a bit seduced, even though like he was a well-intended doctor. So I think there's some that were careless, there's some that got seduced by Purdue Pharma. and the marketing. And there was, I think, a very small minority who were just greedy, corrupt, bad doctors who were essentially drug dealers. And so, on the one hand, that's a small percentage of doctors. So I don't, by any means, want to blame doctors. However, 1 or 2% of prescribers who are all day long writing prescriptions for cash can reach a lot of people. So that very small percentage of corrupt doctors who maybe lost their license, had to move around and set up these practices, they have a huge disproportionate impact to their numbers.
And maybe as a follow-up to that, did Purdue Pharma and the other bad actors, but we keep going back to Purdue as sort of the tip of the spear on this, did they understand the addiction that these could cause? Did they not care? Did they realize it too late?
I think to be as generous as I could, they were hopeful that their coating, which was like a plastic coating on top of the pill, the cotton in the oxycontin, would be effective. But so I give them the benefit of the doubt those first few years. But once overdoses started piling up, they should have said, "Hey, we know something's happening here." Instead, they doubled down and used, McKinsey as a consultant and others to figure out how to extract as much profit for the company from their drug. So, yeah, I think that if not right away, they did know, and it didn't stop them.
So, first of all, I'll go back. What's the name of the show?
Dope sick.
And that's on Hulu.
Yeah, that's on Hulu.
All right. So hopefully we can get Hulu as a sponsor and not Purdue Pharma after today.
Yeah, it's a good show.
So this has been going on, as we mentioned, for 30, 40 years, even longer, going back to, 100 plus years ago, as you started out to say. I'm having flashbacks to nicotine and Philip Morris and, the whole backlash there. Is that something that can be done here, or is big pharma just so big and so powerful and in bed with lawmakers, and the lobbying dollars are just too big that it is what it is, and truth be damned?
No, I would say that. I think there's a lot of reason to be hopeful about what could be done. And in fact, uh, i- they prescribing has been reduced a lot. And it was one of those things where we as a country were slow to sort of realize what was happening, and then we very rapidly, doctors, insurance companies, states, uh, cut back prescribing. Unfortunately, that is a whole story in and of itself because that cutback was done well intended but carelessly. And I don't know, Chris, how much you want to get into that, but one of my hard lessons is that the prescribing reduction was done very recklessly and lives were lost because what should have been done is new prescriptions should have immediately been cut back instead of giving, the high schooler who broke a leg in a sports injury a bottle of pills. They give them, one pill and some ibuprofen, and they'd be fine in the most cases. And same with minor surgeries, a day or two, right? Instead of like a wisdom teeth, a lot of adolescents get that done. And when they used to just give a whole bottle of pills because, from the doctor's office point of view, they didn't want to get calls. We got to refill the prescription. It made it simple for them. So absolutely, for new cases, they could have cut way, way, way back. Um, but for people who had been addicted to these substances by prescribers, they needed time to titrate down. They might have needed access to addiction treatment or alternative pain care, and we were way too careless as a country in how we cut it back. So I feel that's a hard lesson that we need to acknowledge. But we have cut back. Unfortunately, we're still dealing with the consequences of many, many years of decades of overprescribing.
As you're talking through all that, a friend and former classmate of mine was a global war and terror veteran, Iraq and Afghanistan, and has traumatic brain injury from, a lot of IEDs going off around him, and would have really bad headaches. and he'd keep going back to the VA, and they would just keep giving him a bottle of pills after bottle of pills after bottle of pills. And so it stems outside the private practice, it's at the government level, which is interesting to me, given the fact that there's the whole, policy center, the juror part of it. And so, you've touched many times on the marketing of big pharma. We see all the endless parade of pharmaceutical ads on TV. Did pharmaceutical marketing and messaging influence the patients to seek out opioids, or did the marketing efforts focus more on the physicians?
I you know, they used every channel to market and promote. So I think it was both. And word spread like, hey, there's this new pill. It kills pain and has no side effects, and you should ask your doctor. So, advertising, doctors, word of mouth, um, yeah, everything all together. They were all in. They knew this could be a multi-billion-dollar profit center for the company, and it became that through the marketing. I mean, obviously, these are very sophisticated, skillful companies. Like a major drug trafficker, they have a lot of resources.
Good way to put it, because they are major drug traffickers,
Yeah.
unfortunately, legally at this point. Richard, I've seen something about pain being identified around that time as the so-called fifth vital sign. Was there also a cultural shift in America's expectations or doctors' philosophy about pain management that also contributed to the opioid dependency?
Yeah, it's a super important question because on the one hand, it there is some time, I don't have to tell you, right? Some patients who are really suffering, they need pain relief, and they deserve empathy and care, and that's important. But the reality is that pain movement was secretly funded by Purdue Pharma, Johnson and Johnson, these other large companies. For those who are interested in this, funding was secret because you'd see a compassionate doctor as the face of some of these pain advocacy groups, and your heart goes out to them. And we all have family who've dealt with stuff, and we don't want anyone to suffer. So those doctors and speakers may have been very sincere, but they never would have had the platform and the influence that they had if they weren't well funded by big pharma. There's a Senate report called "Fueling an Epidemic," or you could just Google congressional reports on the opioid crisis, or the cause of the opioid crisis. But they found the records of who funded these groups. Once that became public, those groups disappeared. The funding stopped. They couldn't operate anymore. So yeah, it's another channel that big pharma used to influence the American public and soften the ground, soften its resistance to prescribing outside the hospital setting of opioid painkillers.
How do each of these drugs we're talking about compare to the others? So, prescription opioid versus heroin versus synthetic opioid and fentanyl when it comes to potency.
Yeah, they compare these drugs to a morphine dose. And so oxycodone was about 1.5 times the strength of morphine, heroin 2 to 3 times, fentanyl 50 to 100 times, and carfentanil is even 100 times stronger than fentanyl. And these other opioids, nitazines, and orphines, which is a new class of synthetic opioids that traffickers are turning to. We don't quite know, but they're very powerful. And what makes them so dangerous is it's such a concentrated substance that it only takes a few grains per dose, right, to have an influence. So even I mean, drug traffickers aren't the most careful people in the world when it comes to human life, but even a dealer that was trying to make sure they weren't killing their customers could sometimes make a mistake. And also, as I'm sure you and your listeners and viewers understand, it depends on tolerance, right? So a dose of a powder or a pill with fentanyl in it that would just be a normal dose for a daily user could easily kill someone who is using it for the first time. So that's also a factor.
It's amazing how we got here to this point. You just mentioned a new drug that I've never even heard of before. You call it orphine?
It's a orphine. It's a synthetic opioid group.
Oh my God. So just when we think we're turning the corner, the new thing comes out.
Well, the thing is, I don't want to be so bleak because, on the one hand, it's true. There's always something around the corner. But on the other hand, through a lot of hard work by U.S. agencies and some concessions extracted from the Chinese, there has been a reduction in the high quality fentanyl precursor chemicals used to manufacture uh, 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 fentanyl, synthetic opiates, in the availability. So traffickers have been some of this is still under debate, so I don't want to sound like it's some settled science because it's the black market. But what a lot of experts believe is the lack of access to precursor chemicals has reduced the quality and the potency of the fentanyl in pills and powders today, and it's something that's tracked and measured through seizure analysis, urinalysis of drug users, and we've seen a dip, and so we think that. The decline in overdose deaths, which clearly have multiple factors, right? It's complicated. There's more treatment, and there's other more outreach and Medicaid coverage. So a lot of things are happening at the same time, but there has been a reduction in the concentration, which is a sign of success, and where we should be pleased with that, and but also ready for the next thing, and make sure that we don't rest on our laurels because it's a continuing challenge.
I'm glad you mentioned China and some concessions there. I want to get to that in a minute. And this question may predate your time at the White House, but when did leaders realize that opiate addiction was becoming or had become something far larger than an isolated public health problem? And what finally sounded the alarm bells for them in hindsight?
Well, I do remember very vividly because uh, a lot of the effort of the office, especially in the earlier part of my career, I was focused more on the international side. We were focused very much on cocaine, and that was the number one drug of concern. Uh, and uh, and I, and also at this time in the early 2000s, we were also worried about methamphetamine, which was a problem, particularly in the West, and is still a very serious problem. And in fact, it's in a way it's underreported because so much focus is on opioids, but we need to worry about stimulants, methamphetamine, and cocaine today as well. But I do remember when I've coordinated a bunch of the national drug control strategies over my career, and when that's like government speak to be like the lead author and editor, because it's government, so one person never writes the whole thing, right? It lots of people are involved and reviews and editing, but there's usually a coordinator of the whole strategy helping to put it together, and I remember in 2008 when we were putting out the last George W. Bush strategy, we led as in the press release with pills. And I remember talking about it with the staff, like, pills? Well, what about cocaine? What about methamphetamine? And they're like, well, and then we talked about how no, we need to focus on pills. And I would say, just there was a bit of a delay in all of us in government who are busy on these traditional drugs really realizing what was happening at home, and wish we were a bit faster. But by 2008, was very focused on it, and in the Obama strategy, first Barack Obama strategy, which I led the development of, uh, we had a whole section on prescription opioids, and then in 2011 there was a specialized strategy just on the prescription drug epidemic. So around that period, it really became a major focus of government.
So you're talking about all these different strategies with different administrations, and they all have the same goal, obviously, of reducing and ultimately ending, hopefully, the big pharma and pill epidemic. What strategy should we just really focus on now? Because you have a different administration every 4 or 8 years. They're going to have their own people, their own plans. What can we do to sort of reset? You just talked about a Republican and Democrat, President George W. Bush, President Barack Obama, different policies. One of them you led and one of them you helped implement. Should we just scrap everything? Should we take the best of the last 15 years with the plans, or is it just nothing working and we've got to figure out something going forward?
Chris, I mean, the name of the podcast is Next Step Forward. I mean, we absolutely cannot get discouraged because the country has learned a lot and since then, and we do know a lot about what works. In my book, I emphasize on hard lessons, and I should say that, of course, any author loves it for people to go buy their book on available at Amazon.com. But on my website, I have a lot of free resources, richardjbaum.com, so people can check that out if they want to without having to buy the book. But we know what works, but also to execute it, there needs to be some change in thinking. We can't treat addiction like with some 30-day program. It's just not that kind of thing. The success in treatment depends on the quality of the program, but also the duration. People need at least a year of treatment, not necessarily inpatient, but a year to sort of have their to begin have their brain and body recover. And then when they're done with working through treatment after that year or so, then they need transitional support because they have to rebuild their lives, right? I mean, I did used to think when I was younger, like, hey, you go and someone goes through treatment, to create enough treatment slots, they come out the other side, maybe they have to do a second time, they're all good. But it doesn't work that way because if you've been in active addiction for multiple years, you burned a lot of relationships, right? Your friends, your family, your coworkers, right? You may not have a place to live or clothes to wear or any source of income or that healthy social network that all of us need to have fulfilling lives and a purpose, right? A purpose for getting up every day, which all of us need. So, I do think this is a hard lesson because we're America. Like we like to do things quick and easy and get it done and move on to the next thing. But we need to finance, we as a country, right? Insurance companies, states, governments, private sector, everybody. We need to find ways to finance extended treatment for people. And I do think that like VA is doing better. You mentioned VA earlier. I think in Medicaid, there's some important reforms that have been happening in Medicaid where they realize that if Medicaid doesn't pay for transportation or some subsidy for housing, or even in some cases daycare, there have been state pilot programs that Medicaid has supported. Someone won't go to treatment. So they've been filling these gaps. So we are learning, but there is no quick fix. There is no bumper sticker. I mean, I'm all for those great men and women who are trying to man the border and stop illegal imports of drugs and other dangerous substances. We need that, but they're not going to be able to seal the border and stop every drug shipment from coming through. Their work is important. It slows the flow and it helps us identify the trafficking groups and take them down. So the work is important, but there's not a bumper sticker solution. You can't just snap your fingers and solve it. We're going to have to invest in long-term treatment and recovery for our people.
So I'm glad you beat me to the punch, and you mentioned the name of your book, which is Hard Lessons from Inside the War on Drugs, available on Amazon. Where else can they find you? Your website?
Yeah, richardjbaum.com.
So a lot of good stuff there, and highly recommend people go there and buy the book. And I do not get a royalty on that, for the record. But Richard, let's go off script a bit more here. I want to follow up on what you're just talking about
Yeah.
in terms of extended treatment. And I'm having again thinking back to the nicotine crisis and Philip Morris and the big lawsuits and the billions of dollars they got fined. Why can't we come up with something similar to that where big pharma should have to have some skin in the game to help right the wrong that they've done? You think about the cost to individuals and to corporations from the insurance perspective. You mentioned Medicaid, you mentioned insurance companies. They want to see these treatment periods reduced so that they don't have to pay as much. But at the same time, to your point, we need the right treatment plans in place. And it's not 30 days. It's going to vary individual by individual and certainly pill by pill or product by product. Any thoughts in terms of, what could be done? Again, 30,000-foot level from a policy perspective.
Yeah. Well, first off, I have I have proposed a 2% tax on the revenues of pharmaceutical industries to generate $10 billion a year to invest in effective anti-drug programs, including a big effort on treatment. These big numbers we talk about in Washington are a lot, even for us to like keep us Washington wonks to keep track of. But the drug budget overall is it's about 46 billion. Let's just say 50 billion. And in writing my book, uh, I really wanted to put forward a plan on how we could go forward together in combating the drug problem. I wanted to be realistic, so I thought about a 20% increase, uh, over the year because there's an absorption capacity, right? I mean, yes, there are studies that show the opioid crisis cost the country over $1 trillion a year, but you can't just snap your finger and say, okay, give us $1 trillion. Like nobody budgets that way. So my thought is a 20% increase combined with the opioid abatement funds together, that's about a 25% increase. And I really want to make very clear, Chris, to you and your listeners and viewers, is that the post fentanyl 2013 crisis really transformed the drug problem. It used to be people had longer, right, to get to their recovery, but now there's no time. The drug supply is so dangerous that we can't wait around. Those people that are buying and using these polydrug substances, stimulants, sedatives, and opioids, they need to be in treatment. And it's going to take some more money. The Congress should appropriate it. And not that philanthropy, state and local, private sector, other people can help, but I'm calling for new money. And let me mention one more thing. Uh, about only less than a quarter of people with an opioid use disorder, a diagnosed opioid use disorder, actually seek and receive treatment. It's not just that they're not getting it, they're not seeking it. So and there are multiple reasons why, but I think the reason that we should focus on is that people who are dependent on these drugs don't want to go cold turkey. They're using these drugs to cope with daily life, and they don't trust the treatment system in some fancy office downtown to recognize the difficulty. And so we need to go to where these people are, mobile clinics, outreach workers, and start talking to people and engaging with them. And that's in support of that, I've called for 100,000 new recovery coaches funded by the federal government, and a bit of a callback to Bill Clinton's call for 100,000 community police officers. But recovery coaches, of course, they're not all we need, right? We need counselors, we need physicians, we need lots and lots of professionals and people working on it, volunteers. But recovery coaches, they're relatively inexpensive, right? It takes 40 hours for someone to get certified, and we have 24 million people in recovery. And many of them want to give back. They have a passion to give back. Let's hire them, train them, and get them out there because nobody can build rapid rapport with a current drug user like a past drug user. I mean, it's just amazing what they do because there's just an ability to connect and communicate. And I'm not saying the recovery coach could snap their fingers and say, okay, well, come into treatment, but they could start a dialogue and a rapport and get to know somebody and say, hey, we've got this buprenorphine clinic, or here, there's a great treatment doc over here. Let me go over there with you. And they could bridge that gap. So that's one of the things I feel really strongly about. Let's fund treatment and let's hire recovery coaches and let's go to people where they are and stop waiting for them to be knocking on the door of the treatment clinics. They're not coming. We have to go and find them.
I mean, you just rattled off, I mean, I've got half a page of notes here, but three or four or five very realistic, very viable, not complete solutions, but certainly steps, again, next steps forward. Thank you for that plug earlier as well. You know, what has to be done with lawmakers, with presidential administrations? I mean, the 2% tax, I think it should be a no-brainer given the profitability. The 20% increase, maybe not one jump at it, in one year, but scaled in maybe over a 3 or 5-year period. I think that makes a ton of sense. To your point, you sprinkle those on, that's a 25% increase over, we'll say 4 years, we'll say one administration. Recovery coaches, that's brilliant. I'm going to give you the credit, even if it's your idea or not. And with 24 million people in recovery looking to help and give back, it's similar to the mental health crisis we're facing. We don't have enough trained professionals to deal with the crisis. And that is a crisis, especially post-COVID world. This is a crisis that's been going on for 30, 40, 50 years, back 100 plus years with the original morphine, to your point. What do we have to do to get lawmakers to open their eyes, to realize, to understand, to stop accepting big pharma checks for their campaign coffers and actually do what's right, not only for the American people, but for the global civilization? Because to your point, this is coming across borders in here, but then we're sending stuff elsewhere. And so it's a huge, huge global problem.
Well, I wish I had an easy answer to that question, but I think that I just look at the way the country responded to COVID when there was a crisis and trillions of dollars were funded and were needed. Obviously, I'm not questioning
Mhm.
that. I mean, it's such a terrible crisis. So many people lost. But we need an emergency supplemental appropriation for a treatment. And I do discuss, I'm sensitive about spending federal dollars. I know there's a debt and I'm worried about it. But also, what we have to recognize is that it's expensive to not treat people. They show up in the emergency room, in the emergency department. They do commit crimes, usually just to generate funding for to buy drugs, but also more serious crimes from their regular drug use and the stress of that life. And so the cost to society will reduce if we get people into proper treatment, and if we intervene with them earlier in their addiction when they're easier to sort of bring back. uh, I'm also, I talked about recovery coaches for a drug user in the community. Another great idea is to train people in jail and prisons. They can do the virtual training, right? If they're in good behavior and let's say they're in, they have a history of drug use, but they're in recovery, let's give them the training and let them practice and work with their fellow inmates. Because even though there's been some progress on treatment in jail and prisons, it's very difficult behind bars. I mean, it can be done if the warden or the sheriff whoever controls the prison is committed to make it happen. They can get mobile methadone and bring in buprenorphine and have there are these long-acting injectables, not just naltrexone, but long-acting buprenorphine formulations last a month or a week at a time. So it can be done, but it's tough. It's really tough. So let's make sure we are getting some more capacity into the jails and prisons, and ideally we can treat people outside of the jails.
So I appreciate you making your statement about, the deficit and not spending money. And so, for the record too, I'm not suggesting that too. I'm a fiscal conservative. But again, you just gave another great idea in terms of the prisons. And again, their job is to become reformed as they go and serve their sentence and come out the other side and be productive citizens in their communities again. Maybe this accelerates their parole. Maybe this, time off for good behavior type of thing. Again, another great idea. And to your point, there's no bumper sticker. There's no snap your fingers and some pixie dust on this. It's going to take time, resources, energy, some champions like yourself, screaming from the top of the mountain. You know, what can we do to have more people like you out there understanding this? I understand you refer to yourself as a policy wonk in DC, and I love that. As I've got my MPA, so I love the policy stuff. But what else can we do?
Well, I do think it comes down to the people and their campaigns, right, this year. And we should tell our members of Congress who are running or state legislature as well that these are important issues and we need more support. Also, I am working with a group called United Against Fentanyl. That's a national group that is organizing in cooperation with DEA walks around the country on July 11th. There's a website, Walk for Lives, and I could share it with you if you want to put it in the notes for the show. And July 11th, all around the country, there'll be walks bringing together families who've lost loved ones, people who've been affected by drugs, and speaking out about addiction. And on September 26th in DC, there will be a rally, an event in Washington, I believe, on or near the Washington Mall, and we're encouraging people to come out. So I just think people do need to be the squeaky wheel, and uh, and not to be discouraged, because I didn't say the solutions were easy, but there are solutions. Everywhere in the country, there are programs, initiatives that are really helping people, but they're not they're they're not being brought, not being financed and brought to everywhere they're needed. They're just sort of pockets of effective policy and programs. And I do write about this in the book with some uh, in a way, mixed feelings. But the reality is, when you get to have the job I had as acting drug czar for a year, you go and you visit these incredible places, programs inside hospitals and inside prisons and jails and courts, and it's very inspiring. But I think what happens is, those of us who visit model programs, we think, okay, we know how to do this. This will get done. Let's just write about it and talk about it. But it's much harder. And you probably know from your public administration background then, to take a model program and spread it everywhere. It's like you miss some of the details. And so what we need is a deliberate effort to capture what the model programs are, to fund expanding pilots, and then help them monitor them over time. And we can do it. For every part of the drug problem, there are solutions. But what we need are focused, organized efforts to bring these solutions everywhere they're needed.
So, Richard, unfortunately, due to our or my technological issues at the beginning of the show, we lost about 10 minutes. So I have to have you back on the show. One last time here. We just have about 2 minutes left. The name of your book and where can people find you?
It's called Inside America's Opioid Crisis: 12 Hard Lessons for Today's Drug War. And they can reach me at richardjbaum.com, my website. I'm also on LinkedIn a lot, and happy to engage with people. And I would say that there's no reason to be discouraged, but we should be focused on what it takes. It's there's no slogan, there's no bumper sticker. The 12th hard lesson is there's no easy button. And there is no easy button. But if we put our shoulders down and we work together, we can bring the help, care, compassion that people need. And you could do a lot. All of us could do a lot in our faith communities, in our neighborhoods, reach out to people. And people that are struggling, they've lost a lot. Even if they're in recovery, they've lost a lot, and they need support and friendship. Maybe they need a shot at a new job. As we look nationally, we should also look locally about how we can help sort of recognize this problem and lift people up who are trying to find their way back.
Those are some incredible closing remarks. I really, really appreciate that. And, Richard, thank you so much for the important work that you're doing. As we know, America's celebrating its 250th birthday in just a few short weeks. And for us to see the next 250, this is a crisis that needs to be addressed both sides of the aisle, everywhere globally, not just the United States, but this is a global epidemic. And so, again, really, really appreciate the work that you do. So thank you personally.
Great. Thanks for having me on, and look forward to having a discussion again later on, and maybe hearing from some of your many viewers and listeners. This is an important problem, and we have to go forward together.
We do. I'm Chris Meek. We're out of time. We'll see you next week, same time, same place. Until then, stay safe and keep taking your next steps forward.